Welcome to my YouTube channel. I am Dr. Ahmed Al-Baghdadi. I'm here to talk about anatomy of the heart, clinical correlation part 1. The subjects dealt are pericordium and penetrating trauma, anatomical interpretation of chest X-ray, heart auscultation. Let's start with pericordium and penetrating trauma. The pericordium refers to the area on the anterior chest wall that overlies the heart and its related structures. It is the surface projection of the heart and includes regions such as the sternum, costal cartilages, left fifth intercostal space where the apex of the heart is located. Clinically, examination of the pericordium plays a crucial role in assessing the size, shape, and position of the heart, as well as detecting abnormal heart sounds or murmurs. By palpating and auscultating this area, healthcare professionals can gather important diagnostic information and identify potential cardiac abnormalities or conditions. The heart lies on the middle mediastinum, between the lungs, behind sternum. It sits on the central tendon diaphragms, slightly tilted to the left. About 2/3 of the heart lies to the left of the midline and 1/3 to the right of the midline. So, a major part of right ventricle is anterior to the left ventricle. Right atrium is anterior, inferior, and to the right of the left atrium. Left atrium forms the most posterior part of the heart. Pulmonary orifice of right ventricle anterior to the aortic orifice of the left ventricle and to left. Therefore, in spite of the heart is protected by the sternum and thoracic cage, it's still susceptible to injury. Especially during penetrating trauma, like, for example, a stab wound. The right ventricle is the most commonly injured structure because of its anterior position in the chest and the fact that it forms the majority of the anterior surface of the heart. Followed by the left ventricle, which forms the apex of the heart and may be injured as far laterally as the left midclavicular line at the fifth intercostal space. The atria are less commonly injured than the ventricles. Now, we shift to second subject in this presentation, which is anatomical interpretation of chest X-ray. Here, we take about 3 topics. First, heart silhouette. Heart silhouette refers to the cardiac shadow in chest radiograph, and it also represents the mediastinal shadow. The left border of cardiac shadow, formed from above downwards by aortic arch, pulmonary trunk, left auricle and left ventricle. The right border formed from above downwards by SVC, right atrium, IVC. The second topic in anatomical interpretation of chest X-ray is the positive silhouette sign. Positive silhouette sign occurs when the normal heart silhouette on an X-ray is no longer visible due to a pathological process directly contacting the heart. For example, if there is consolidation in the right middle lobe of the lungs, it can obscure the X-ray silhouette of the right border of the heart, making it difficult to visualize. Notes that the left image is a normal chest radiograph with the red line indicating the silhouette of the right heart border and right middle lobe, while the right image shows the same red line delineating where the silhouette should be, but is lost due to consolidation in the right middle lobe. The last topic in the anatomical interpretation of chest X-ray is cardiothoracic ratio. The cardiothoracic ratio refers to radiographic measurement used to assess the size of the heart in relation to the thoracic cavity. It is obtained by dividing the maximum transverse diameter of the heart by the maximum transverse diameter of the thoracic cage. Cardiothoracic ratio can provide insights into the size of the heart and potential cardiac abnormalities. Generally, a cardiothoracic ratio of less than 0.5 is considered normal, indicating a relatively small heart in relation to the thorax. On the other hand, a ratio greater than 0.5 suggests an enlarged heart, which may be indicative of various conditions, such as congestive heart failure, cardiomyopathy, valvular heart disease. The last subject we discuss in this series is the heart auscultation. Before we start, you must know that because the valves in the heart are situated close to each other, it can be difficult to distinguish their individual sounds. However, we can hear the sound of a valve in a different location than its actual position by listening in areas where the blood carries the sound. These areas are specific for each valve where the blood has passed and in line with the valve opening, allowing us to clearly hear the valve's sound. Now, let's start with the aortic valve, which is located posterior to the left of the sternum at the level of the third intercostal space. To auscultate the aortic valve, you need to move your stethoscope at the second intercostal space, right of the sternal angle. The pulmonary valve. It's located at level of the left third costal cartilage, and is auscultated at the second intercostal space, left to the sternal angle. The tricuspid valve. Its location is posterior to the body of the sternum to the right side at the level of the fourth and fifth intercostal space, and it's auscultated at the fourth or fifth intercostal area, left to the sternal edge. The mitral valve. It's located posterior to the sternum at the level of the fourth costal cartilage to the left, and is auscultated at the left fifth intercostal space on the midclavicular line. If you liked the video, press the subscribe button to receive all new. What's next is more exciting.